On our presentation today, we are going to look at the best ways we can communicate with autistic individuals, the best way we can communicate with autistic patients or even friends. The most important thing we want to look at is that we are able to send our message and communicate so that the autistic people can get to understand us. My name is Tendai Kwari, and I'm doing my doctoral research at Oxford Brookes University, Autism in Education. And I've just completed a master's at University of East London, where I did special educational needs master's, specializing in autism as well. And currently, I'm working with young persons who are autistic, trying to outreach to communities and support them as well and give some training. So today we are going to look at autism and communication. Our keywords is autism, communication, autism spectrum disorder. Now, throughout this report, the term autism is going to be used to include all conditions to the autism spectrum, whether autism spectrum disorder, autism spectrum condition, or other terms such as Asperger syndrome, atypical autism, or pervasive developmental disorder. So in line with current practice, this report is going to use identity-first language. For example, an autistic person rather than a person with autism. I can say a person with autism only when I'm making a quote. So you can see from the definitions I got here, first of all, autism is a developmental disability characterized by atypical social interaction, interests of body movements, and communication. And from that definition, you can see that social interaction is communication. So we are not talking of verbal communication, our daily conversation communication as we know it. The second definition from American Psychiatric Association, DSM-5, says that autism spectrum disorder is a complex developmental condition that involves persistent challenges in social interaction. Again, social interaction is to do with communication. Speech helps with communication and nonverbal communication. The effects of autism and the severity of symptoms are different in each person. And this, I have to emphasize that when you meet one person who is autistic, the symptoms, the conditions, they are totally different from another autistic person you meet. A diagnosis of autism now includes several conditions that used to be diagnosed separately: autistic disorder, pervasive developmental disorder, and Asperger syndrome. These conditions are now called autism spectrum disorder, hence the word spectrum. There is often nothing about how autistic people look that sets them apart from others, but autistic people may communicate, interact, behave, and learn in ways that are different from most other people. And this is the reason why you hear this word neurodiversity. We have got a strong movement of autistic professionals, autistic medical persons, autistic researchers who are driving for neurodiversity, which means that we have to look at autistic people communicate with them, and understand that they think differently. That's all. There's nothing abnormal about being autistic. It's simply because they think differently. That is neurodiversity. So, I'm looking here on double empathy. What double empathy means is that when autistic people and those not on the autism spectrum attempt to interact, it is both that they have a problem, both parties. The problem is not on the autistic person only of communication, it's on both parties, non-autistic and autistic. And this is called double empathy. This phrase, double empathy, came to be discussed more in academic circles after a researcher, Milton, explained that communication is a two-way system, and he called it double empathy problem. And I was very fortunate to be a student of Professor Milton when I was at the University of East London. So many autistic people use compensatory strategies to mask their overtly autistic behaviors when spending time with others, thus allowing them to fit into their social surroundings. Some terms could be masking, others can say camouflaging, others can say coping tactics. But all of that happens because autistic people want to blend in. They want to fit in. They don't want to be seen as being different from the non-autistic people. But however, this may lead to burnout. Imagine yourself trying to live the life of someone else every day, every hour. You definitely burn out from that. This can lead to suicidal, depression, loss of self-esteem, missed, late, or questioned diagnosis. What you mean is diagnosis can go wrong because an autistic person is camouflaging, is masking the real characteristics of who they are. So from the DSM, the definition of autism spectrum disorder fall into two categories. And these two categories have got to do with communication. Category 1, social interaction and communication problems include difficulties in normal back and forth conversation, reduced sharing of interests or emotions, challenges in understanding or responding to social cues such as eye contact and facial expressions, deficits in developing, maintaining, understanding relationships. So they can struggle to maintain, develop relationships. It could be a relationship between a boyfriend, a girlfriend, a relationship between a child and a parent, any type of relationship you can think of. It has to be developed. It has to be maintained. But they can struggle with that. Or they may not even understand you are trying to start a relationship. Category 2, the effects of restricted and repetitive patterns of behavior can be hand flapping, toe walking, or playing with gadgets in an uncommon way. For instance, one young person I know would like to set some objects on the table in a certain way. These objects, to me, or to someone who is not autistic, you might not think you need to take them to your table in the office, but he really, really treasures them. They're lined nicely on the table all the time. Some may speak in a unique way, such as using odd patterns or pitches in speaking, having significant need for a predictable routine or structure. That is a very important point about structure, about routine. Autistic people do so well on structure and routine. I'll talk about it in the next slides. Some of them can exhibit intense interests in activities that are not common to you and me who are non-autistic. Again, another big thing which is going on research now is the sensory issues. Autistic people experience sensory issues in an unusual or extreme way, such as indifference to pain and temperature. They can feel the pain so much or not feel the pain at all. They can have issues with excessive smelling or touching of objects, even their own fabrics, on their own body. Some can have fascination with lights and movement, and some can get overwhelmed with loud noises. For instance, a small sound to you, but to an autistic person, it can be like a large explosion. And then you see them responding like putting their hands over their ears continuously. And then you wonder why. What they're trying to do is to shut off that sound, to ignore that sound so that they can concentrate on what is happening. So we have to know that many autistic people have different ways of learning, paying attention, and reacting to things. So autistic persons, children or adults, some may not point at objects to show interest. They can just maybe tell you, I want that. What is that you want? That's what I want. They cannot point, some of them, especially if they are young and children. And then some cannot look at objects when another person points at them as well. They have trouble relating to others or not have an interest in other people at all, which connects again with communication. And avoid eye contact. We know that eye contact, facial expressions is so important when you communicate, because you can read what the mood of the other person is now. But if they cannot read that, it's so difficult for them. Some prefer not to be held or cuddled, or they might cuddle only when they want to. Or some may appear to be unaware when people are talking. So these are some of the things and signs and symptoms we can see. And on the other hand, some may be very interested in specific persons, not everyone, but not know how to talk, play, or relate to them. Some may repeat or echo words, or repeat words or phrases in place of normal languages. Some have trouble expressing their needs using typical words or motions. And then others can repeat actions over and over again. And I spoke earlier about having trouble when a routine changes. So you need to maintain the structure and routine. I keep repeating that all the time. Now, this is the context. We know that most autistic people are adults now, but many of them are undiagnosed. And many of them do not have an intellectual disability. But however, of those known to services, many have a wide variety of physical and mental conditions. This association means that for many, their first professional encounter will be with adult psychiatry. It could be general rehabilitation, forensic, old age, liaison, or some other specialty. Some will have problems that relate immediately to autism, including those seeking a confirmatory diagnosis. But most will come with symptoms of an assortment of psychiatric disorders. So the context will complicate the presentation and management further. This includes where and how they live, the people and the service available. And at this point, clinicians, professionals, we encourage them to get in touch with families, with parents, with other services to have a bigger holistic picture. The prevalence, changing concepts and diagnostic practice over the last 30 years have combined with greater awareness to increase the number of people identified as autistic. Yes, although there is an association with intellectual disability, the current estimate is that autism is present in at least 1% of general population, of whom most are adults. Autistic people are at greater risk of co-occurring psychiatric disorder. That's Rosen research in 2018. Therefore, although autism is present in about 1% of the general population, actually it goes up. It is encountered in 3 to 5% of mental health service users. And this research was done in 2020. Its presentation and management being affected by their co-occurring disorders. And this again will color, for example, their communication, flexibility and ability to engage in the clinical process. Overshadowed, the autism may go unnoticed, or conversely, its characteristics be so amplified by stress that everything is ascribed to autism and any other issues are missed. So differences in social interaction. I've mentioned this earlier about social responsiveness, which is restricted, inability to take part in meaningful to and fro conversation, especially in groups. Hence, some autistic people, you find them sitting by themselves in a corner. They are looking so content. They are happy doing what they're doing at that time. Because some have a reduced initiative, understanding of how others might think or feel may emerge as a difficult in understanding the nuances of social situations. And let me just say off thing here. In autism, this is called the theory of mind. What we mean is that theory of mind simply means that they can struggle when something is presented to them to put it in context, whatever the situation could be, because they've got a reduced intuitive understanding of what is happening. In the long term, there may be difficulty in making and maintaining reciprocal friendships. I've said that earlier as well. So the clinician, wherever possible, it is essential that the clinician gets accurate accounts of the individual's social relationships and interactions in different settings, at work, at home, and particularly how they manage more demanding situations. Difficulties with non-verbal expression can show in an unusual use of gaze, facial expressions, or gesture elements, which may be poorly integrated with each other as well as with what is being said. The lack of communicative gaze is distinct from the persistent downward cast gaze that may be seen in shyness or depression. Speech may have a pedantic correctness, lack vivacity, be unusually even in pitch, pace, or consistently too loud or too soft. And therefore, the mismatch of emotional expressiveness is dangerously misleading. Anxiety can be masked by a fixed smile, an annoyed frown, or an angry response, and any of which can lead to serious misunderstanding. Many appear relatively impassive, giving a matter-of-fact account of their predicament without the facial expression, gesture, or other signals that might indicate their distress. And as a clinician, you can easily miss that. And again, that links with masking, camouflaging, and those coping tactics I mentioned earlier. Others, trying to blend in what goes for normal in their culture, may use exaggerated expression and gesture. And can I just say at this point, the word normal is worrisome. What is normal? Who said what is normal? It's the community. The community, the society, tends to impose what they deem, what they think is normal on other persons. But what can be normal in one set can be abnormal in the other set. So you can see what society does. And this is where we say we need to have a society that follows what you call social model of disability. That's accommodating any differences amongst human beings. Because if we try to say this is normal, we are imposing ourselves what we think should be done onto other people. So that's another topic I would like to discuss in the future. What normal is normal. So let's move on here. So there can be equivalent difficulties with nonverbal comprehension and an autistic person, unable to interpret a speaker's facial expressions. They also can't pick that from other people. However, verbal communication is usually less problematic, particularly if the material is written rather than spoken. So you can have things written down for autistic people, show them, but at the same time, do not assume that because someone can cope with a structured question and answer dialogue, they can cope with formal conversation. So the clinician must guard against this and check regularly that it has been understood. And I'm coming now to what you call the emotional blindness of alexithymia. Alexithymia is associated with autism and can limit the individual's ability to recognize, label, and describe their own emotions. Non-autistic people, you can describe how you feel to other people, but autistic people, some of them cannot. I quote Serrani here, who said this in 2014. Sometimes I work with children and adults who can't put words to their feelings and thoughts. It's not that they don't want to, it's more that they don't know how to. So, a few examples, those with alexithymia experiences are difficulty identifying different types of feelings, limited understanding of what it causes feelings, difficulty expressing feelings, difficulty of recognizing facial cues in others, limited or rigid imagination, constricted style of thinking, hypersensitive to physical sensations, detached or tentative connection to others. So the result is that the individual, preoccupied with experiences that pass unnoticed by others, can appear distracted, daydreaming, or even hallucinating. The degree of sensitivity varies, but can be so intense as to produce overwhelming and incapacitating distress. A heightened awareness of certain tastes and texture may lie behind very selective eating. And there's a lot of research going on about the intersectionality of eating disorders and autism. So, we have discussed already about unusual sensory responses. And if you really want to have this copy, It's printed for you, but I've discussed about different sensory issues already. Let's move to inflexibility. Inflexibility, this can result in someone set their eyes, fixed routines. We discussed about this as well when I was saying they want a structure. But what I want to emphasize here is inflexibility differs from obsessive compulsive behavior, in that the autistic individual does not feel the behavior to be alien and there's little desire to change, particularly if it is something they enjoy. For instance, I've got a young person, I was doing a workshop with them and everyone was engaged on what we're doing. Actually, it was a young group of computer science programmers. But there was one girl who was so fascinating. She was following all the discussion, everything I was doing, but she was continuously drawing on a book. Beautiful art, piece of art, so beautiful. I tried to talk to her, why are you doing that in the first place? She said she wants to do that. And she asked me to carry on with my presentation, my discussion. She was getting it on. So that is not obsessive compulsive. She really wants to do that. So what to watch? We talk of that autistic people may mask, mimic a wide range of psychiatric symptoms. So the mental state examination should confirm that the symptoms are what they are. Do not assume. For example, alexithymia may hide anxiety or depression. Hallucinations may be inferred mistakenly in someone who is detached or who suddenly becomes distracted. A confident claim of many friends may be misleading. For example, you ask them, have you got some friends? They can say, oh yes, I've got loads of friends. But they are talking of Facebook friends, not the real friends they can meet every day. So in all this, the clinician needs to find a balance between overlooking autism and seeing it all around. And finally, I need to talk of cultural interference here. Autism comes with a lot of stigma. Some cultures, they put a lot of stigma. They stereotype autistic people to such a point that some autistic people from these cultures will not come forward in fear of what the community, what society will say about them. And again, this brings camouflaging, masking, copying tactics. So those embedded in a culture which masks the features of autism, like in prison, military, religious establishments, because they've got a predictable routine and a very social hierarchy, autistic people thrive in that environment because it's structured, it doesn't change. In some organizations like these, things are the same for the last 20, 30 years. The routine is the same, so they can cope very well. But that doesn't take away the autism in them. And others as well, as I said, if they're in communities which are dominated by other disabilities, such as hearing or visual impairment or intellectual disability, it could be so difficult again, a difference between autism and other co-occurring, conditions. So in judging the significance of a symptom, the clinician will need to take into account what is the norm for that group. And again, yesterday, I just did a presentation where we were saying that we want to have more autistic professionals, more autistic clinicians who are also from marginalized ethnic backgrounds. Because communication comes into play when you've got clinicians, autism specialists, autism doctors who are alien to the cultures of some communities. It's a barrier on its own to accessing services. But that's another topic I'll discuss in the future. So, access can be helpful by staff and public education. We need to be more autism aware. We need to use online booking and communication wherever possible to avoid asking autistic people to come out. Some can't even go on a train, get a bus pass. They find it challenging. And again, at the same time, some may struggle talking over a phone. And the use of hospital passport, which is a document carried by autistic persons. And I use these hospital passports a lot. I know some autistic young persons, some of them, they put it around their neck like a lanyard. You read on it. It has got how to treat that autistic person, how to talk to them, what they want, what sort of sensory issues you need to minimize. Do you need to have lights that are dimmed? Should you turn down the sound of music? It tells me already, and it makes my life easier when I'm working with them. So the presenting difficulties and of autistic individual, including their autistic characteristics, will be improved by anything that reduces their anxiety or increases their physical comfort and sense of well-being. Better communication and social understanding. Improved environment, which they are more familiar, which is predictable with reduced sensory stimuli. Relief of physical pain, for example, the relief of pain or discomfort. The better management of epilepsy, because some autistic people have epilepsy as well. So it needs better management, better sleep and medication, and the treatment of co-occurring psychiatric disorders. Access to services presents a hurdle to many autistic people. I've mentioned that, even coming out to go in a train or bus, because there's a lot of unfamiliarity, it's so unpredictable, or they can have difficulties with communication in using a phone, talking to the public. So as clinicians, again, we need to find a way whether we need to go to their homes or they can do better over a phone. So autism-friendly psychiatric units should be adapted to autism. If you don't have that facility, look around in the organization where there are suitable facilities. Then you can meet there with the autistic people. Staff buildings and programs should be structured, predictable, and calm. When you talk of staff buildings, my recent research, which was my dissertation for my master's, was on the universal design of buildings, how we can have buildings that are universally designed so that disabled people can access those buildings without any challenge. If we do not have universal buildings, universal environments, we as society, we are disabling the disabled. In that case, the disabled are not disabled. They are disabled by society. So remember to have regular routines, consistent responses, use clear and visual communication, have restricted number of people in your clinic wherever you meet them, even staff, so that the individual can get used to them. The units need to be attuned to the individual patients rather than work to some generic, non-specific concept about autism. And there needs to be an emphasis on regular staff training in autism, especially communication, to avoid stagnation on the development of relationships with other specialist autism services, and on input from autistic input. So continuity is what I'm talking about here. Same staff, small number of staff, same building, environmentally friendly to sensory issues especially. So thank you very much for going through my presentation. Some of the articles I've put on ResearchGate, which If you want to read, I'm still building up more documents on ResearchGate, but I would like you to go onto this presentation on YouTube, subscribe, and also you can share with your friends. Thank you very much for sitting through all this presentation.